So good morning, good evening, good afternoon, depending on where in the world you are. And I'm Dr. Shabnam Daskar. I'm a functional medicine consultant. And I have resisted for a long time talking about cholesterol because there's so much to talk about it that I'm always afraid that I won't be able to do justice and go down rabbit holes. So today I said, no, I finally have to start focusing, talking about cholesterol because people are so confused about all the numerous messages they get. So what is it about cholesterol? So is there something called good cholesterol? Is there something called bad cholesterol? And the other major area I want to talk about is, people sometimes, and I'm sure doctors are also responsible for giving that impression that heart disease, particularly in what in medical terms we call atherosclerotic cardiovascular disease, that means heart disease that gives you a heart attack like a myocardial infarction, which happens because the blood vessels supplying blood to your heart get clogged and they don't get sufficient blood supply to those areas, and that is when you have a heart attack. Sometimes that the impression people have is heart disease, that type of heart disease is a plumbing problem. It's like you have these vessels supplying the heart, and fat goes and collects in those arteries and it gets clogged, and that is why someone has a heart attack because blood cannot reach beyond that point. Now, that is definitely not true. So the other important, statement that I want to make is heart disease is not a plumbing problem. And what about the good and the bad cholesterol? So as always, I will need a PowerPoint to share. Okay, here I am. So last month, I talked about hypertension, and hypertension, cholesterol, all these things are intimately related. Okay. Oh, and another thing is all the previous webinars, I have asked you all to type in your questions in the chat box. Now I have figured out how to let you all speak. So this time you can ask me questions either in the chat box is always there, or I will unmute you if you raise your hands, and you can ask a question as an audio as well, but there is no video. So going beyond good and bad cholesterol. So this is one of my patients, and this is one of many. And if you are South Asian, you will know that this is a very common history. 42-year-old South Asian man, self-employed. He loves his work, lives in India. He's been happily married for 10 years, 2 healthy children. He's a non-smoker. Now his waist to hip ratio is 1.2. So what that tells us is that he has belly fat. You can see the number that for South Asians, waist to hip ratio should be less than 0.9 in men, and in women it is less than 0.8. For other people, non-South Asians, the ratio is less than 1. Because South Asians have more belly fat, they are more metabolically unhealthy at a lower body weight. That is the reason these numbers are different for them. And you've noticed that I have not mentioned BMI here because BMI is a very poor measure. Next is his father passed away at the age of 60 from a myocardial infarction. So myocardial infarction is a heart attack, and mother has hypertension. Now, I don't meet any South Asians who don't have this kind of a history, family history. Next is his blood pressure is 140 by 80 millimeters of mercury, and he's on medication. Now hold that number in your mind because I'm going to bring back my patient story at the end again. Next is his fasting blood glucose is 98 milligrams per deciliter, and those of you who are used to the millimoles, it's 5.4. His HSCRP, which is a marker of inflammation, it could be chronic or acute, is 2.8. That is very significant. His sitting disease risk is high because a lot of his work involves sitting in front of a computer and also commuting, and he doesn't drive himself. He has a driver to drive him around. So he spends a lot of time sitting in the car as well as in the office. That is very significant. Now, sleep history, if I don't have time at the end of it to talk about it, just remind me, and I'm going to mention a few things about sleep. Because sometimes what happens is, if you are not using a wearable or you are not diligently checking your sleep, sometimes a lot of people make the mistake of thinking that time in bed is actually the time they have spent sleeping, and that is not true. Because if you are awake in bed for many hours, like you just stay in bed for 45 minutes to 1 hour wide awake trying to get sleep, then you are not sleeping obviously for the entire 8 hours that you spent in bed. Your actual sleep time is much less, and that is what is called sleep efficiency. So that is very important as well. So his sleep history I don't have in details. So for years and years, I'm sure even your doctors have told you about the good cholesterol and bad cholesterol. You may have gone for an annual health checkup and you had a lipid profile. So a lipid profile is a test which everyone everywhere in the world can get it done. This is not a specialized testing. So what are the tests they look for? I'll come to that in the next slide. So HDLC is high density lipoprotein cholesterol. As I always say in medicine, I think we like long words, and big words makes us sound very clever. And LDLC is low density lipoprotein cholesterol. So LDLC is usually called the bad cholesterol. And the other thing a lot of people try to remember it as is L is low. So you want your LDL low. And HDL is supposed to be your good cholesterol. So H is high. So higher HDL is supposed to be better. Now, the fact is, when you do a lipid profile study, test in the lab, the first number that comes up is usually the total cholesterol. Now, LDL-C and HDL-C are actually the carrier proteins. So cholesterol, because it is fat, it cannot move around in the blood by itself. So it needs to be transported from one place to the other. So how LDL-C got the name of bad cholesterol is this thinking that it goes into your blood vessels directly, the blood vessels that supply the heart and the brain, clogging them up. So that is again the analogy to a plumbing problem that I mentioned at the beginning. And HDL-C is supposed to be the good cholesterol, which takes cholesterol to your liver. Now, as you know, our bodies are not as simple as that. So this view of good cholesterol and bad cholesterol is, number one, highly simplified, because the fact is, this is where what really gets me concerned is, so for my particular patient, this is what his report was looking like. Total cholesterol, it's absolutely in the lab range, so most doctors would have no concern about that. Now, triglycerides, I have talked about triglycerides numerous times before. As you can see, it is outside the lab range, and 180 milligram per deciliter is extremely high. So here again, this is not only high in terms of being outside the optimal range, it is also outside this lab's range. So what would be an optimal triglyceride level? Now, opinion varies, but the thing is, triglycerides around 120 milligram per deciliter. Some say it should be nearer to 60, but that's not so easy to reach that level. So 120 would be probably much better, definitely not 180, and definitely not 160. So some labs have the upper number as 150, but I look at it more as 100 to 120 would be a better number. Now, this particular person, my patient, his HDL-C was 43.5, which according to this lab is absolutely fabulous. And LDL-C is also very good. So if we were to look at these lab numbers as just from the point of view of good and bad cholesterol, that is HDL-C and LDL-C, he is fine. So my concern is when we focus only on cholesterol, so HDL-C and LDL-C, we may be missing the boat completely. Because the fact is, for heart disease to occur, there are about 400 different risk factors. As my fellowship, metabolic cardiology fellowship teacher, Dr. Mark Houston says, there are about 400 different risk factors for cardiovascular disease, that is heart disease and stroke. And out of them, about 25 are modifiable. So I like to focus more on things that are modifiable rather than things that are not modifiable. So modifiable meaning things that you can change based on your lifestyle and treatment and medications. Those are the things I'd like to focus on. So yes, LDL-C is what most doctors are concerned about, as they rightly should be. But my point is, I'm not saying cholesterol is not important for in relation to your risk for heart disease and stroke, but to focus only on LDL-C and HDL-C is leaving out all the other different, so many risk factors, which you can have a role in changing that. So triglycerides is another major risk factor, which is not often mentioned because, and particularly for women, having a higher triglyceride level is a much bigger risk factor than LDL-C and HDL-C. So number one point is not to focus only on HDL-C and LDL-C. Yes, they're important, but they are not the only ones. And the other important thing is, are you focused only on the numbers, or are you focused on their actual long-term health? So this in medicine, we talk about surrogate endpoints versus hard endpoints. So surrogate endpoint meaning an LDL-C level is low, but does that give you the protection long term if you're looking? So what you or I as a patient or a doctor, what am I interested in? As a doctor, I'm interested in making sure my patients live long and healthy lives. So having a low LDL-C, does it ensure that? I don't know. So that is why LDL-C is what we call a surrogate endpoint, versus when they do clinical studies, if they are looking at long-term deaths, how early are these people dying who have high LDL-C, or are they having more of heart disease and stroke? So those are the hard endpoints that we are looking at. So focusing, bottom line again, focusing only on cholesterol is not enough. And more importantly, it's not just what the number is. The most important thing is what is being done to that cholesterol. That is extremely important. Then there are other levels of levels that come, and I'm going to briefly talk about a few. The other thing I want you to remember very importantly is the triglyceride by HDL-C ratio, and I'm going to talk about it later when I talk about particle number and size. So sorry about that, complex looking slide. So when we talk about cholesterol, it's extremely important to mention, so these are the proteins that help the cholesterol move around. So lipoproteins are many different types. And in a standard lipid profile, quite often it is not even the actual lipids that's measured. It's also sometimes derived from an equation. So obviously that is not 100% accurate, particularly if someone has high triglyceride levels, that is not accurate. But you can see that there are numerous other lipoproteins that are extremely important. So here, two important ones is, one is small LDL versus large LDL. So when you get an LDL measure, it's not going to, a routine standard laboratory lipid profile does not tell you how much of the LDL is small LDL and how much are the large. Now, when it, again, I don't want to make it sound very complex, because this test, which looks at the size of the lipid particles and number, that test is not available everywhere in the world. In India, it's, as far as my knowledge goes, it's not available yet. In the US, it is available. In Canada, we have to ship it to the US. In the UK, I am not sure it's available. So I don't want to focus on things that you can't get done right away. But it is important to know that you would rather have large, fluffy LDL particles than the small LDL. But again, there are many levels of complexity. Then are the LDL functionally, okay, or are they not functioning well? Similarly, it is with HDL as well. So here you can see that there are so many different lipoproteins, and out of them, we are only looking at LDL and HDL, but then VLDL remnants, intermediate density lipoproteins, IDL, these are also all important. So again, going back to my, the message that I want to give is, it is not enough to focus only on LDL and HDL numbers on a standard lipid profile. There are so many other things that need to be looked at, because the major concern I have is some people think if their LDL and HDL numbers are in the range, they are okay, they are safe from heart disease or stroke, and they don't need to bother about their lifestyle, what they are eating, whether they are sleeping enough, whether they are moving enough, whether their blood pressure is under control. That is the message that I want to give, that it's not enough to just focus on your LDL and HDL. So heart disease is not a plumbing problem. Now, many a time you must have heard, as I have heard, many doctors describing it to patients as, okay, you had an angiography. So that is where they put in a dye, they inject a dye and they take pictures of the blood vessels in your heart. And you are told you have a 40% blockage, you have a 30% blockage, you have a 70% blockage. Depending on what is going on, whether you presented with a, with chest pain, you may be recommended, an angioplasty right then and there. My point is, heart disease is not because, so these are two vessels, blood vessels. So let us assume these are blood vessels supplying blood to your heart. So this is a normal artery and blood is flowing normally. This is one where, this is narrower because there is atherosclerosis. So atherosclerotic plaque. This is the thickening of the arterial wall, which makes it narrow. And obviously, the narrower it is, the lesser the blood supply to the part that it is supplying to. Now, one erroneous thinking is that this is a gradual process. This happens slowly. There's a little bit of, plaque formation. So the erroneous thinking is that 70% block is, worse than a 40% block. Whereas the fact is that is not always true. Because what happens is, going back to the plumbing problem, this is not a gradual change in the size of the artery. So this is not like 50% becomes 70% tomorrow, and then once it becomes 90%, you get complete, blood supply to the rest of the heart to the part of the heart is lost and you get a heart attack. No. What usually happens is what we call a plaque rupture. So a small part of this this can dislodge and get lodged into a narrow part of the artery, and that can give a heart attack. So my point is, a 70% block is not necessarily worse than a 50% block. The point is, we still don't know enough on how to predict which particular plaque, whether a 50% block or a 70% block, is going to have a plaque rupture and cause a heart attack. So if you think that just because you have a 40% block in one artery versus someone else, your friend who has a 70 or an 80% block, that you are safer, that is not true. So more than 50%, probably more nearer to 60% of heart attacks have happened in people who have had 40 to 50% blockages, not necessarily 70 to 80 or 90% blockages. So because it's the part of the plaque that gets dislodged and gets blocked and gets lodged into a narrow part of the artery. So again, don't go by just my 40% block is fine, because it is not, that's not necessarily true. So there is always a risk of simplifying something. So if you think of a plumbing problem, it's like, okay, 70% block is much worse than a 50% block, but that is not always true. One of the major factors that decides whether, what is going to happen to the plaque, whether it will remain, in medical terms, we say it's a stable plaque or an unstable plaque, one of the major factors is inflammation. So if heart disease is not a plumbing problem, what kind of a problem is it? This is again from my fellowship professor, Dr. Mark Houston's work. He talks about, infinite insults to the blood vessel. Your blood vessel will respond with 3 finite responses. Now, this slide looks extremely complex, but then I know many of you are physicians, so you're used to, going through complex material, but I'm trying to, so just ignore all these things. Look at the infinite insults. All the infinite insults, it could be nutritional insults, it could be infections, it could be heavy metal toxins, it could be other environmental toxins like environmental, hormone disrupting chemicals, EDCs that I've mentioned, things that come out of your plastic bottles and, plastic food containers. Those are toxins as well. Or it could be like, given the ongoing coronavirus pandemic, now the COVID, the virus has shown, has shown results, has shown to be harmful in heart disease. So the virus, a viral infection, and not just the coronavirus infection, it could be other viral infections as well. Those are all the numerous insults on the blood vessels. It could be, high blood pressure. If your blood vessels are not very soft and pliable, they have become hardened by atherosclerosis because of the ongoing, challenges that the blood vessel is dealing with. All those things impact the blood vessel. So heart disease is not a plumbing problem. It is an inflammation and immune dysfunction problem. And all the sort of the drama is happening at the level of the blood vessels that supply, and particularly the membrane that is, we talk about many episodes ago and several webinars before, I talked about leaky gut. So in my functional medicine world, we talk about leaky membranes. So it's leaky gut. And then for heart disease and stroke, it could be leaky blood vessels supplying your heart, or it could be a leaky blood-brain barrier. So your brain also gets, supplies of nutrients and everything else from the rest of the body. And when someone has, a neurodegenerative disease like dementia, Alzheimer's, any of these, it is also a problem of the leaky blood-brain barrier. So whatever happens in the gut can reach the brain, and that is where it has to overcome the blood-brain barrier. So it's what we call a, heart disease, any brain problem or, gut issues is multiple membrane disease. So the different membrane barrier functions are impacted, and all of them, for example, inflammation is sort of the common pathway amongst all of them. But as you know, there are different types of inflammation. That's not just, one kind of inflammation, though we usually tend to talk about inflammation like a catch-all phrase for everything. So all these numerous insults to your blood vessels, how does the blood vessel respond? Inflammation, oxidative stress, and immune response. Now, the thing is, inflammation, as I mentioned about my patient whose HSCRP was high. So HSCRP is a blood test. You can do that anywhere in the world. Ideally, that should be less than 1. But first and foremost, if you find it's high, your doctor needs to rule out any acute infection. If you have a urinary infection or you've had a cold recently, that can raise it. You are going through some kind of pain, you fractured a leg or you sprained your ankle or something. Yes, HSCRP can go up. But there are lots of other markers as well. Commonest is HSCRP. Oxidative stress can also be measured, but that is more of a specialized testing, so I'm not going to talk about it today. Immune responses can also be measured, again, specialized testing, so we don't always need to do that. But the problem is your blood vessel will have these finite responses, innumerable insults, but 3 finite responses. So basically, my point is, heart disease is not a plumbing problem. It is a problem of inflammation and immune dysfunction. So if that is the only message you go home with, I would definitely feel that I've done at least part of my job. So when you go to a doctor, what are the top 5 risk factors for heart disease and stroke that every time you'll find people talking about? It is high blood pressure, diabetes, cholesterol abnormalities, or in medical terms, atherogenic dyslipidemia, obesity, and smoking. Now, I'm not going to talk about smoking. You already know that if that is a problem, then that is something that you need to address right away. Next comes, so if bottom line is, this is where I have all my, my concerns are, because let us say these are not your problems. Does it mean that you're absolutely safe? You don't have any risk for heart disease or stroke? That is not true. So that is my concern, that just focusing on the top 5 risk factors, and particularly for women. I mean, I've had so many women, coming and telling me when they they went to the ER with a chest pain, and they didn't have these risk factors. They were told, like, you don't have the risk factors, so why did you have a heart attack? This is not true. I have talked about women and cardiovascular disease before. So you know that there are so many other risk factors, like the 400 different risk factors I talked about, and the 25 modifiable. This is only 5 of the 25 that you can change. So my point is, you have more things under your control to manage your risk versus, feeling I have heart disease in my family. My father had a heart attack in his 40s, or my brother has a heart attack, or my, uncle had multiple angioplasties. Everyone in my family has diabetes and cholesterol problems, so I am destined to go down that path. That is not true. That is the most important message I want to give across. So I am not going to belabor more on this particular slide, because if you've heard me speak before, you've heard that it's when I look, or anyone like me in functional medicine looks at any health problem, we look at all these different areas. It's not just a cholesterol centric approach, and it's not just only your diabetes and blood pressure. All these different areas impact all those things that are extremely important. So next thing is, if I were to look at, let us say in the ideal world, I have all the testing available to me, everything is possible. What would I do for this particular patient of mine? Number one is a 24-hour ambulatory blood pressure test. If you remember, and I'm going to show that patient history again. If you remember that his blood pressure was 140/80 with medication, definitely that is not a normal level of blood pressure for a 42-year-old man. It should be nearer, or at least lower than 120/80, whether it is with medication or medication and lifestyle. That is what I'd look at. But 140/80 is definitely not okay. And I talked about 24-hour ambulatory blood pressure and home blood pressure monitoring before. So the standard guidelines for hypertension now recommend that it should be out of office blood pressure checking. So not checking your blood pressure only at the doctor's clinic. That is not enough for diagnosis. So the other thing with the 24-hour ambulatory blood pressure test is you get to know what your nighttime blood pressure is. And that is extremely important information. And there is no way you can get that information with even home blood pressure monitoring. So for all my patients, I recommend the 24-hour ambulatory blood pressure test, particularly the ones who've told me, my doctor said my blood pressure was high, now it is normal. So as if you have worked with me as a patient, you know that I'll always ask, what do you mean by normal? Your doctor's normal and my normal may be different, because I am looking at, what is going to happen to you for the next 40, 50 years of your life. And I want to make sure you're safe. So for that, a 24-hour ambulatory blood pressure test is extremely important. With home blood pressure monitoring, if you are my patient, I have to keep reminding you all, you need to do this, send me the numbers, otherwise I can't decide. So yes, we still don't have a wearable that will just check your blood pressure in the background. Next is a very important test called the coronary artery calcium, the CAC score. I'll talk about a little bit about that. And the fourth one is the NMR lipid particle number and size. I don't want to talk about the NMR lipid particle because, as I mentioned earlier, it's not available everywhere in the world. But if it is available in your country, I would highly recommend you get that done and don't go by just what your lipid numbers on a standard lipid profile shows. So if you have the option, please get that done. And most importantly, find a practitioner who can understand how to interpret that report and tell you what to do. Because this is like very new information about dysfunctional HDL. So HDL, the so-called, the good cholesterol, most people are very happy if it's very high. Now, the fact is it may be high, but completely dysfunctional. So that again is going to, you see your HDL numbers, they are high and you're very happy. That may not be true. If they are dysfunctional and you won't know unless you do this test, then there are things that could go wrong and you wouldn't know, and you'll wonder what happened. Like my doctor said my cholesterol was normal, then why did I get a heart attack? So that is where some of those answers may be. Now, coronary artery calcium test. So this is again there is this is called the CAC score. Some people call it the CAC score. So what happens is you go to a center where they have a CT scanner and they put in a dye, and then your heart vessels are actually checked on that CT scanner, and it comes up with, there are some calculations and all that, and it'll come up with a coronary artery calcium score. So studies have found that those who have a score of 0 versus those who have a score of 400, let us say, or more than that, those with a score of 0, regardless of what their cholesterol numbers are, they are at a much lower risk for heart disease and stroke long term. Versus someone whose cholesterol numbers may be normal, but if they have a CAC score of more than 400, definitely they are not at low risk for cardiovascular disease. So CAC score is a much more relevant test, but there are challenges, and particularly for women, this is a really big one. And another area where, whether you should be on a statin medication or not, obviously that is a question you need to discuss with your doctor. But many of you read a lot about statins. And if you want to read more, I would suggest that one of the best, it's not a very long book, Dr. Malhotra's book called My Statin-Free Life. It came out recently, and he is a cardiologist in the UK. So Dr. Malhotra's book is really very good. He explains the science very well on, do you need to take a statin? So if your doctor has recommended you need to take a statin medication, and you want to know more whether you should take or you shouldn't take, doing the CAC score test is extremely important. Now, unfortunately, in countries like India, where people have to pay out of their pocket for every test, a CAC score test is not very cheap. It's, last time I checked, it was around 15,000 to 18,000 rupees. So in Canadian terms, that would be about $300 or $400. However, this test is available in Canada on healthcare, but your specialist will have to recommend it. In the US, I've heard, and again, I don't have patients in the US, I've heard that it can cost as little as $50 to about 150 to 200 US dollars. So even if it costs 200 US dollars, that is a very worthwhile test to do. So depending on where you are in the world, and in the UK, I have no idea. I would assume that the NHS does cover it, but you need to ask your doctor about the CAC score test. So that is a very important test to be done. Now, going back to my patient. So what are the risk factors I can address? Number one, if you go by the traditional top 5 risk factors, he's a non-smoker. And I didn't mention his BMI because, like I said, I don't go by obesity as BMI. So he has a high waist to hip ratio, so belly fat. Now, what does belly fat mean? You've heard me talk about insulin resistance before. So belly fat means your insulin carbohydrate metabolism is not working well. So obviously having a lower carbohydrate diet would help you. Incorporating some time-restricted eating, intermittent fasting into that will help. Now, I think in December, I'm talking about intermittent fasting, time-restricted eating. You can, but Mikhal and I have lots of other videos, you can go through them. The other thing is his father passed away at the age of 60 from a heart attack. Now, usually in South Asians, heart disease starts much earlier, at least a decade before the rest of the Western world. So though 60 is an early age, and in the Western world, we consider as 55 as early cardiovascular disease. In South Asians, we don't consider the age at all, because being South Asian itself is a risk factor for heart disease and stroke. So regardless of what your family history is, if you are South Asian, you are at a high risk. But my point is, just because you're South Asian, just because you have a lot of heart disease and stroke in your family, that does not mean, and you have hypertension today, it does not mean that your life is doomed. No, your family history, your genes do not decide your destiny. Next, I talked about his blood pressure already. So my goal is to get his blood pressure to 120/80 or below with medication and lifestyle. So initially it might be because medications work much faster than lifestyle. So while I'm waiting for his lifestyle to kick in, I'm going to definitely make sure that number one, does he have nighttime hypertension? If he has nighttime hypertension on a 24-hour ambulatory blood test and he is not taking his medication at night, first is to switch the time when he takes his medication. The next thing is I will very likely add another medication with this agreement with him that once he, let us say he loses his belly fat, because of weight loss, his blood pressure can go down. If his insulin resistance is managed better, his blood pressure can go down. But while I'm waiting for all those things to happen, I still want his blood pressure down, tomorrow if I can. So I am going to recommend more medicines for some time. So some of you find that, if I add one or two more medications, it's like as if it's like your personal failure. No, that is not the impression I want to give. The important thing is, the goal is to get your blood pressure down, and most of the time it involves medication, supplements, lifestyle, everything together. So while we wait for supplementation and lifestyle factors to kick in, I would definitely like to bring down your blood pressure if it involves adding one or two more medications. From my personal opinion, that is okay for some time. Next is his fasting blood glucose of 98. Now, one of the top five, one more risk factor is diabetes. So in traditional lab reports, you would say that this person does not have diabetes, but a fasting blood glucose of 98 in my functional medicine world is not okay. Ideally, it needs to be around 85 to 90. So again, fasting blood glucose can go up. One of the commonest is if you're eating more carbohydrates than your body can tolerate. And CRP, I mentioned already. So what are the things that I'm going to focus on right away? Sitting disease risk is very high. So he sits about 8 to 9 hours a day, like I said, at the office and his commute. So I would suggest that let us start focusing on how to reduce his sitting time. So things like I use a laptop stand. So my laptop is on a stand, and I made it a point to, I'll always stand for my webinars, for my patient consults, and I make sure that my chair is not nearby so that I'm not even tempted to just sit down. So my chair is like a little far away because my husband might use the chair, but I don't want to sit down. There are some conditions when I might want to sit if I've been, standing for a long time for many meetings at a stretch. Next is sleep. So these are the things I would focus on first rather than focusing only. And if you remember, his cholesterol was, so this is his cholesterol, his LDL-C and HDL-C, the so-called good and bad cholesterol are okay, but I am definitely concerned about his triglycerides. And triglyceride by HDL-C ratio. So this is a simple ratio that you can derive from a standard lipid profile. And if it is more than 2.5, this indicates that the chances of you having, dysfunctional cholesterol, the small, dense LDL is higher. So this is kind of like, a surrogate marker of, in medical terms, atherogenic dyslipidemia. That means basically bad lipids. So if this is high, now how will this number come down? As you can see, his triglycerides is high. So if his triglyceride levels go down, this ratio will definitely be lower. So this ratio needs to be less than 2.5. So rather than focusing on increasing HDL some more, I will definitely focus on triglycerides. Yes, HDL is extremely important. Exercise is one of the ways to increase HDL. But the fact that even if his HDL was higher, the very fact that he has high triglycerides, that still makes it a high risk factor for him. So this is something I'm going to focus on. One way is a lower carbohydrate diet. The other way is to add high dose omega-3 supplements. So there are some that are available as prescriptions, but ideally I would love to test for your omega-3 levels, and omega-3 testing is available in many countries. It's available in India as well, I've recently found out. So if you are interested, I can just send me an email at info, info @drkarmd, drkarmd.com, and I'll send you the link on how you can get the testing done for omega-3s. So bottom line is, it is much better to focus on things that you can modify. So what are the non-modifiable risk factors? South Asian ancestry. Obviously, he cannot change his ancestry. I have already talked about family history. So don't let your family history make you feel, that this is what my health history is going to be. That is not true. Numerous studies have shown that lifestyle changes can change your risk dramatically. So what are the modifiable ones, like I've mentioned already? So the point that I'm trying to make on this slide is there are more modifiable risk factors for heart disease and stroke in this man than there are non-modifiable. So the modifiable ones are the ones that we can work on and change. Changing things like, getting your blood pressure to target. Yes, I won't say it is easy, but it is possible. And you need to be a little more focused. Like I ask my patients, you need to measure your blood, check your blood pressure at home more often, and get a 24-hour ambulatory blood pressure test done to know what your nighttime blood pressure is. Then reduce triglycerides. My first recommendation is low carbohydrate food, time restricted eating, have early dinner, if you are someone who has late dinners, and omega-3 fatty acids. These would be the main ones. Interrupt continuous sitting, find out different ways, use a treadmill desk. That would be one of the best. So standing all the time is also not the best. The best is you need to interrupt your continuous sitting by 5 to 6 minutes of doing something else. You can just go for a walk. Maybe if you are someone who works from home like me, don't keep water on your table, so that you can you can interrupt your continuous sitting by going and getting a glass of water. Or if you drink tea like I do, go and make another cup of tea every hour or so you're at least moving around. So the point is to interrupt the continuous sitting. Reducing chronic inflammation. One of the commonest sources of inflammation among my patients is food. So food sensitivities, eating a lot of processed food, eating the wrong kind of cooking oils, eating more carbohydrates than the body can tolerate, those are the ones which cause inflammation. Then another source which is often, falls below the radar is gum inflammation. So periodontal disease. So you need to go to a dental surgeon to find out if you have any gum issues. That inflammation is also related to heart disease and stroke risk. Belly fat, like I said, so weight loss would be one of the best ways to manage your risk. And lots and lots of newer studies are coming up which are showing that if someone has diabetes, regardless of what their body weight is, what it means is, and this is based on the work of Dr. Roy Taylor from the UK, what he says is it means you are above your fat threshold. So your body has a certain threshold of fat. If you have diabetes, regardless of what your actual weight on the scale is, even if it shows that you are sort of not at a high BMI, it is still more fat than your body can tolerate. So fat loss more rather than weight loss, because we don't want you losing your muscles. Fat loss is important, and it can reduce high blood pressure. It can reduce your risk for becoming a full-blown diabetic. It can reduce, even if you have diabetes today, it can reduce your risk for long-term health. It can reduce your risk for, heart disease, stroke, dementia, mental illnesses, cancers, you name it. Any disease can get better with weight loss. Of course, the right kind of weight loss. It's not like, because cancer itself can cause weight loss. That is not what I'm talking about. So that is all from me. And like I said, I can let you speak. So if you just raise your hand or feel free to type your questions in the chat box. If you have any question, just feel free to ask. Or type. Okay. I don't see any raised hands or any questions yet. If you want to ask, I can unmute you, allow you to talk. Okay, so thank you very much for investing your time with me. And I do hope you've learned something new. Would any of you like to share something that you learned today, and more importantly, something that you're going to change in your own health, rather your behavior, healthy behaviors, anything you want to add, anything you want to subtract, any conversation you want to have with your doctor? Would any of you like to share anything? Okay, I don't see anything. I so miss live events and being able to see people and talk to them. And, that is something I miss so much. But thanks to technology, at least I know many of you can join. Okay, I can see one raised hand. Go ahead.
Hi, I have a question. Nowadays, a lot of rheumatologists and doctors say to avoid dairy for people with autoimmune disorders because it causes inflammation. I was wondering, has dairy always had this effect, or is it because of the genetic modifications and the, antimicrobials that they're giving the animals and farms?
Thank you very much. That's an excellent question. So, truthfully, I don't think I can give you one definite answer because it is many things together. Yes, you're absolutely right. Dairy today is not what it was before. So, that could be one of the factors. The other important factor is many people are, sensitive to dairy. Now, when it comes to food sensitivities, you've probably heard me speak about this before. Some people may be sensitive to the milk, but the cheese is okay or the yogurt is okay. So we don't know the exact reason why dairy is inflammatory for some people, but it's not inflammatory for everyone. So, and there is no one test which can tell you whether dairy is a problem for you, other than eliminating dairy from your food for at least 2 weeks and reintroducing them one by one to see which dairy containing food is a problem for you. Or if you are tracking your inflammation markers, yes. Because the other thing, Nan, is for a lot of my patients who are vegetarians, things like cottage cheese, paneer, cheese, other kinds of cheese, those are actually very common things that they eat often. So it's important to know whether dairy is a problem for you specifically, rather than just a blanket recommendation from your doctor saying that you need to stop everything. My point is you need to find out whether it's really a problem for you. So yes, while I can't really say whether it is the processing, but definitely that makes a difference, because obviously the milk that we have now, like sometimes I get so confused, there's like 2% and something else percent, and what happened to full fat milk? you know so yes, that could definitely be a contributory factor, but it's impossible to know whether it's just that or it's also how your body is reacting to it. Does that answer your question?
Yes, it does. Thank you so much.
You're welcome. Thank you. So anyone else, any other questions? So you will receive a recording of this webinar, and if you think of any questions later on, do let me know. Bye now, and thanks for investing your time with me.